afternoon. Hello, everyone. Thank you all for joining today's AOA guest speaker, Dr. Thompson, and the Tulane School AOA representatives. Our speaker today will be introduced by Kyla Street. Kyla, it's yours.
And Ashley Vellucci, two of you.
Yeah, so hey everyone, my name is Asha Vellucci. I'm one of the current fourth years at Tulane. I'll be introducing the speaker in addition to Kayla Street, who's also a current fourth year at Tulane. We're on the leadership board for Tulane's chapter of AOA. So it is with our pleasure that we introduce to you Dr. Alexis Thompson. Dr. Thompson currently works in the division of Hematology Oncology within the Department of Pediatrics at Ann and Robert H. Lurie Children's Hospital of Chicago. She completed her medical training here at Tulane University School of Medicine and received her MPH at the University of California, Los Angeles. She went on to complete her residency in pediatrics at the Children's Hospital of Los Angeles and went on to do a fellowship in pediatric heme-onc at the Children's Hospital of Philadelphia. She is hematology section head at the Ann Robert H. Lurie Children's Hospital and a professor of pediatrics at Northwestern University. She is a recipient of numerous awards, most recently the Gwen Hazen Cherry Family, Stephen A. Frieg, MD, Endowed Lecturer Award, and the Alexander S. Weiner Memorial Lecturer Award. Her clinical interests include hemoglobinopathies such as thalassemia and sickle cell disease, and bone marrow failure syndromes, in addition to stem cell transplant in pediatric patients. And now I'll hand it off to Kayla.
Thank you, Ashley. Currently, she is an investigator on multiple center trials, in addition to her own institutional clinical studies in thalassemia, ITP, and sickle cell disease. Dr. Thompson is a pioneer in the field of sickle cell disease, and she works to better understand and treat hemoglobinopathies. She has been a leader in multi-center collaborations and has numerous involvements in professional activities, such as the NHLBI-funded Thalassemia Clinical Research Network and the Sickle Cell Disease Implementation Consortium. Dr. Thompson was elected to AOA as a faculty member, and she represents the very best Tulane has trained. We are proud to introduce Dr. Thompson to you all. Dr. Thompson will be presenting the AOA Medicine Grand Rounds. Thank you.
Well, thank you, Kayla and Ashley. I hope you all can hear me. This is really a pleasure. My biggest regret is that I'm not there with you, but we're hoping to work on something as the pandemic allows in 2021. But it's my pleasure, and actually I'm terribly excited to talk to you about advances in sickle cell disease. And I think it's easy to say that there really is a cure within reach. This is a space that really has some really exciting advances that really, I think, represent game changers. And these are my disclosures. So I'm hopefully going to cover quickly the pathophysiology of sickle cell disease. It's changed over time, current therapies, some emerging treatments, and then what our future challenges are. So I believe this slide is one that should be familiar with most of the audience. It really has not changed much. Sickle cell disease is the most common inherited blood disorder in the United States due to a single point mutation in the beta globin gene that results in an amino acid change that causes a change in the characteristics of hemoglobin, such that hemoglobin polymerizes within the red cell under certain adverse conditions. Most common one is low oxygen. And that this shape change results in vaso-occlusion, which is the classic manifestation of sickle cell. It's worth noting, however, that there are modifiers of sickle cell disease that we've learned about over time, not the least of which is that some patients with sickle cell disease happen to have high fetal hemoglobins naturally. We now know that this is probably due to a mutation or variance in the promoter of gamma globin, which is just upstream of beta globin on chromosome 11, and also variants that are naturally occurring in a gene called BCL11A. We know that we can modify sickle cell disease with transfusions, which will reduce hemoglobin S and increase their total hemoglobin. And we can also induce hemoglobin F with drugs like hydroxyurea, which I will also describe. we're now learning that if you can come up with mechanisms that will silence certain factors, that you can increase fetal hemoglobin and also modify sickle cell disease. So while the focus has typically been on sickle hemoglobin polymerization as the signature manifestation of sickle cell, we now know that sickle cell disease also involves endothelial dysfunction, reduced nitric oxide bioavailability, inflammatory mediators that are produced by white cells, and then platelet activation, that all of these things are in play. And so this amazingly complex interplay is really what all the different mechanisms that are in play clinically. This is really important when we try to understand what is really going on in the patient. But I think another particularly exciting aspect of this is that it now allows us to conceive of additional druggable targets for sickle cell disease. Sickle cell, again, for being such a simple genetic mutation, has an amazing array of complications that at this point, one can argue that it affects almost every single organ system in the body, with both acute and chronic manifestations that are almost from head to toe. Probably the most devastating are those that involve the brain, with either acute strokes or neurocognitive deficits that appear to be chronic, retinopathy that can lead to blindness, sickle cell lung manifestations like acute chest syndrome and pulmonary hypertension, liver dysfunction, gallstones, skin ulcers, priapism in men, just an amazing array of very serious complications. Nonetheless, the life expectancy of sickle cell has improved over time. So the very first description of sickle cell in Western literature occurred over 100 years ago in 1910. Not a lot of progress over the intervening 60 years, until in the early 1970s, the National Sickle Cell Control Act was passed, which led to the creation of comprehensive sickle cell centers, which were intended to be primarily academic medical centers that not only specialize in sickle cell care, but were really committed to advancing the field in terms of research. And so that steep incline really represents the research contributions by those comprehensive centers. It led to breakthroughs like the understanding in the 1980s that penicillin prophylaxis would result in an 83% reduction in infections in children, the use of hydroxyurea in clinical trials, which I'll describe a little bit more, and then using transcranial Doppler to identify children who are at risk for strokes and transfusing them as primary stroke prevention. And so while I think that, that certainly this represents a trajectory that continues to increase today, I think it's important to point out the disparity between sickle cell disease and all Americans, that the improved life expectancy we certainly have seen in sickle cell disease, but it lags behind the overall US population by almost 3 decades. Sickle cell disease mortality is not an equal opportunity offender. We certainly can see risks of mortality across the age spectrum, but the group that I think continues to be most concerning to most of us in the field is this increase in death between the ages of 15 and 45. And so clearly an opportunity for us to have an impact on what we would consider to be excess mortality. And we have made progress. So when I look at these 3 superimposed curves, these represent 3 major trials that were looking at the state of sickle cell disease. And so in 1979, remember, this is what was before we were doing routine newborn screening. I think fast forwarding to 2006, all 50 of the United States now have universal newborn screening for sickle cell. But in 1979, you can certainly see this peak in mortality for children under the age of 5 that represented the natural history of the disease at the time. Improvements in 1999 when essentially the most populous states had adopted newborn screening, and so we were no longer losing children before the age of 5, at least in the United States. Then we had the introduction of hydroxyurea in the late 90s. And so now in 2017, we're seeing more sickle cell patients survive into adulthood. It's amazing to think of having people who are 85 years plus who have sickle cell disease, but certainly it's telling us what's possible. Having said that, the survival, again, is still well lower than the general population. And so with S beta 0, which are the more severe forms of sickle cell disease, the median survival is age 48. And for SC or S beta plus thalassemia, it's 55. So clearly an improvement over time, but far lower than the general population. I mentioned that there are a number of therapies in the pipeline, and many of those therapies actually now target specific manifestations of sickle cell disease. So I'm really going to highlight those that have actually moved through the FDA approval process. And really, if I gave this talk 2 years ago, I would be talking about one drug. And I pause on that one because I think for those of you in medicine and pediatrics and elsewhere, just imagine if for your favorite disease, you only had one drug. How much progress could you have possibly ever expected to see in that disease with one drug? My hope is that we're just seeing the beginning of efforts that really are bearing fruit, looking at druggable targets for sickle cell disease, because certainly with one drug, it's not surprising how little progress we've made until recently. Hydroxyurea is an old drug. It's an old chemotherapeutic agent that's been now repurposed for sickle cell. So in addition to inducing fetal hemoglobin, it causes some degree of myelosuppression, which reduces inflammation. It can improve your total hemoglobin, so relieve anemia. The cells that are expressing higher amounts of fetal hemoglobin are less prone to hemolysis, and it increases nitric oxide bioavailability. There have been a number of clinical trials over the last 20 plus years, and sickle cell, at this point, I think there is no question that hydroxyurea reduces sickle cell pain and acute chest syndrome. It decreases the severity of pain. It reduces the number of admissions, and you have shorter hospital stays. It also extends your lifespan. So there are now adult trials showing that hydroxyurea being taken for any period of time is associated with a reduction in deaths. Yet there are barriers to its more broad use. These are some of the other agents which have now been approved. L-glutamine is also called Indari, reduces red cell oxidative stress and hemolysis, and was approved by the FDA in 2017. 2019 was a bonanza year for the FDA in that they approved GBT440, which is also called Vaxelator, which was the first rationally designed anti-sickling agent to be developed and to move through the approval process. And then crizanlizumab, which is a p-selectin inhibitor that inhibits the interactions of red cells with the endothelium. This is looking at the benefits that we're seeing in L-glutamine, irrespective of how active your sickle cell disease is. So this is a forest plot that looks at patients who either have infrequent vasoocclusive episodes, 2 a year, or versus those who have 6+ a year. And regardless of how common you are seen for treatment for pain episodes, there seems to be benefit for using L-glutamine. Vaxelator is, again, as a sickle inhibits polymerization of sickle hemoglobin, and at 2 different dosing levels compared to placebo, there was an improvement in the total hemoglobin. And the rationale for that is that as an anti-sickling agent, you decrease the amount of time that sickled red cells are hung up in capillaries and therefore are being subjected to low oxygen conditions and a propensity to sickle. And so that by achieving that, one can actually reduce the degree of hemolysis and increase the total hemoglobin levels. It's been approved as an oral agent once daily for anyone over the age of 12. Crizanlizumab is a p-selectin inhibitor, and it was found to actually significantly reduce the time to the first vasoocclusive pain episode on therapy, as well as increase the time between the first and the second pain episode. It is infused as a monthly treatment in an infusion center, and was approved in November of 2019 for patients over the age of 16. And while I think that those are certainly some very exciting findings, what about cure? And this has become really a recurring conversation with many of my patients. And I'm really thrilled to talk about some of the progress that we've made. So hematopoietic stem cell transplantation for sickle cell disease has been known to be curative since the 1980s. And so that allogeneic stem cell transplants with an HLA matched sibling donor should be the standard of care, especially in children. We now know that we can also achieve cures in adults, and that was not possible until recently, that attempts at transplantation in sickle cell in adults was almost uniformly fatal. But that now, using an approach that focuses on immunosuppression and less on myeloablation, we're seeing really promising results in adults. There's also interesting research that's being done using allogeneic transplantation, but using unrelated donors and also haploidentical donors, most commonly parents, but also potentially siblings. Then gene therapy and gene editing have now made their way into the clinical space, and I'll share with you some exciting early results with those. But I think at this point in time, I think it's safe to say that myeloablative transplants using HLA matched siblings without question is curative. This is looking at 1,000 HLA matched sibling donor transplants that took place around the globe in Europe, in South America, and in North America. And what we can find is it really offers excellent long-term outcomes with really some risk of mortality and complications like graft versus host disease. But compared to most conditions for which we do transplantation, this is quite acceptable. Mortality certainly is higher in older patients, and the event-free survival has improved in the last 10 plus years, largely the result of improved HLA typing as well as supportive care. Why gene therapy and why now? These are really important concepts, not just for sickle cell, but for other conditions. Fundamentally, what was required was for medical research to reach a point where you could identify diseases based on mutations. And so the key candidate genes thus far that have moved into the clinical space for gene therapy have by and large been diseases that we know are caused by errors or mutations in single genes. We also needed to discover the tools to replace what is missing or defective, and that this has evolved over time. It has been incredibly useful to have animal models. This is not always essential, but I think for many of us who have spent parts of our career in the laboratory, even when we think we've identified a key regulatory gene, being able to have an animal model that actually has the phenotype of the human disease and to demonstrate that correction or replacement of that single gene will eliminate many of the characteristics of that condition has really been terribly important for us to study not only new agents, but to also envision gene therapy. And then finally, this last one has taken us, the last step has taken us now the last 10 to 15 years, and that is to find ways to safely deliver those healthy genes to long-living cells and to achieve levels of whatever was missing, whether it be a protein or an enzyme, at high enough quantities for an extended period of time to make a difference. And so these are just a short list of some of the conditions, at least the blood disorders, for which gene therapy is currently in clinical trials. And that includes hemophilia A and hemophilia B, which are both bleeding disorders, a number of different forms of immunodeficiencies. My favorite two are thalassemia and sickle cell disease, and I'll share with you some of the results in sickle cell disease. What is gene therapy? Gene therapy in its most simple form is experimental techniques that uses genes to treat or prevent disease. The patient serves as their own donor, and so that is also a fundamental aspect because after all, most of us do not have an HLA matched sibling. And this is just something that we have not been able to overcome. As we have smaller families, the likelihood of an individual with any condition having an HLA matched sibling is low. And so with gene therapy approaches, we overcome that because the patient is their own donor. I'm going to be talking today mostly about engineered viral vectors that are used to insert normal copies of a single gene that's defective or modify its function. I'm saying this in 2020, but I believe that by the end of 2021, we'll begin talking about approaches to gene therapy that in fact do not involve.
You're muted.
I'm going to unmute myself. Is that better?
Yes, much. Thanks.
Okay, great. So I think a lot of people want to think about gene therapy as a gene correction, where you take out an abnormal gene and you insert a new one. Let's just say that does not happen. And so while gene correction is the ideal, it is certainly not one that we can approach today. Instead, what we see more often is gene addition, where we can introduce copies of a normal gene, but leaving the native gene intact. And that's important when I show you the results in sickle cell disease. We can also modify the expression of other genes that play a role in disease phenotype and pathogenesis. Again, something that we're already able to do. And I'll show you some of the very early and exciting results in genome editing. So in the hemoglobinopathies, if we're looking at gene addition, perhaps if we're going to add, for instance, a normal copy of beta globin, the gene that is defective in both thalassemia and sickle cell, in sickle cell disease, because we leave the natural gene intact, the native gene intact, it will convert patients to sickle cell trait, and in thalassemia, reduce their need for transfusions. We can also do this approach gene therapy by increasing their fetal hemoglobin. We can do that by increasing expression or output from gamma globin. Gamma globin is one of the building blocks for hemoglobin F. We can also make beta globin more gamma-like. Babies with sickle cell disease do not have symptoms when they're born, and it's because they are making predominantly hemoglobin F. And so if we can make beta globin more gamma-like, perhaps that would actually be a benefit. And we can also alter the expression of genes that regulate gamma globin. This is actually a list of all of the different vector constructs that are currently in use in clinical trials for sickle cell disease and thalassemia. There are a number of things that these have in common. All of these different approaches are using a lentiviral vector, which at the current time is the vector class of choice for hematopoietic stem cell gene therapy. The most common vector, in fact, for all of these is HIV-1, a lentivirus that we actually understand tremendously and are able to re-engineer to make it replication incompetent and therefore safe to use, but is actually a virus that we know can infect non-dividing cells, and so is particularly useful when we think about hematopoietic stem cells.
Wow.
And so this is HIV-1 that has been completely reimagined, but is the vehicle to deliver beta globin in most instances, but at least in one approach, they're using it to deliver gamma globin. And then in some of these, there actually have been mutations that have been made in beta globin for certain benefits. And almost all of these are using the beta locus control region. This is the LCR is actually the natural engine that drives beta globin production in our red cells. And so it eliminates, yet again, another concern that arose in early gene therapy, and that was using viral vector promoters, which can sometimes go awry. This is actually the natural sequences that would normally control beta globin and would make it red cell specific. I mentioned that we can alter beta globin or a beta globin gene to make it more gamma-like. And so one representation of that is T87Q. So a single naturally occurring amino acid substitution that in fact occurs in gamma globin, but that will inhibit lateral contacts in the globin tetramer that makes up our normal human hemoglobin. There's also another mutation called AS3, which will inhibit polymerization by increasing affinity to alpha globin. And so again, a lot of our basic science work that's gone over decades, it's now being applied in ways to benefit patients directly. I'm going to talk about Lentiglobin BB305 because this is the one for which we have the most clinical data. Again, this is a lentiviral vector that is replication defective and self-inactivating that includes the human beta globin sequences under the control of the beta locus control region. And again, these are erythroid-specific globin regulatory elements, which will allow it to only be expressed in red cell precursors. This amino acid substitution in this particular construct will inhibit sickle polymerization. It also, however, has an additional feature that we found to be incredibly useful for both sickle cell and thalassemia, and that is when we add the T87Q mutation to this modification to the beta globin gene, it allows us to see that beta A that's produced from that, separate from the beta A that would be from transfused red cells, separate from the patient's native beta S or sickle hemoglobin. And so we're able to monitor patients using a peripheral blood test, looking and identifying hemoglobin that is produced from the transgene. This is what lentiglobin gene therapy looks like. Hematopoietic stem cells are collected either by bone marrow harvest or by mobilization. And mobilization in this case is done by plerixafor. And then using an automated process of apheresis to collect stem cells. These cells are then sent to a centralized laboratory where they're CD34 selected and then transduced with the BB305 lentiviral vector. Hopefully this vector will be taken up by their stem cells, and then it undergoes a series of safety checks before it's cryopreserved. In the meantime, the patient has gone about their daily life with no issues. Once their cryopreserved product, however, returns to my institution, the patient is admitted where they undergo myeloablation with busulfan for conditioning, and this serves two purposes. It makes space in the actual marrow for these new stem cells. Patients with sickle cell and thalassemia have hypercellular marrows, and so there is no selection advantage for these corrected stem cells, and so one physically has to make space for them in the marrow. It's also important to eliminate as much of the patient's endogenous stem cells as possible, because again, they will, if you do something less than myeloablation, their native cells will compete for these corrected cells. The patients are given busulfan for 4 days. They have 3 days of rest, and then their drug product, which is their stem cells that are now corrected, is infused. They remain hospitalized until they have stem cell engraftment, and then they're discharged home and follow for 2 years. During that time, we hope to see a continued recovery, and then ultimately production of red cells that now have contain hemoglobin A T87Q as part of their hemoglobin molecule. Per the FDA's requirement, these patients are asked to be followed in a long-term study for up to 15 years. And this was the proof of principle for this approach. This was a boy who was transplanted in Paris. This was a child who'd had a stroke and was on chronic transfusions. And so his hemoglobin was primarily hemoglobin A from the blood bank. He underwent gene therapy, and within 3 months, we begin to see in the pink or red the appearance of hemoglobin A T87Q in his peripheral blood, but also his hemoglobin S. Yet by 12 months of age, 12 months out from his infusion, he now has at least half of his hemoglobin that cannot sickle. So his hemoglobin A T87Q plus a little bit of fetal hemoglobin. And so he would otherwise at this level look like someone who has sickle cell trait with a near normal total hemoglobin. And so this actually launched a US trial at 6 sites to actually reproduce that. And this was actually in the days when we thought the only way to harvest stem cells was from the marrow itself. Yet we learned that for patients with sickle cell disease, that their marrows are remarkably hypoxic and inflamed. This led to actually fairly poor stem cell harvest yields, and as a consequence, very low numbers of CD34 cells collected. We also had low transduction efficiency, and even with conventional doses of busulfan had inadequate myeloablation. And so this combination led to suboptimal engraftment of transduced cells. A number of changes have taken place. Patients are now transfused to quiet their marrows down and hope to make them a little bit more healthy. They now undergo plerixaphore mobilization and apheresis to collect their stem cells. We have a more careful process that avoids hypoxia in the purification process, and we've enhanced the transduction process, hopefully to achieve more cells that actually have vector in them. And we've also optimized the busulfan dose that the patients are given, all of which we hope would enhance engraftment. And this is data in group C for the HGB 206 trial where this approach was taken. And we have patients out to 24 months. I have the first patient in group C is one of my patients. He reaches the 3-year mark in November. But as you can see, patients with 3 months or more follow-up after infusion, they're maintaining hemoglobins of 11 or higher, with both total hemoglobin and also the hemoglobin that is vector-derived, hemoglobin A T87Q. They do continue to make their own native hemoglobin S. And so they will have hemoglobin S and that they produce over time in green, plus the vector-derived hemoglobin that they make from following gene therapy in red or pink. And again, with hemoglobins that I think most of us would find more than acceptable of over 11. What's most important, though, is where is this hemoglobin fraction? Because remember, when I look at a hemoglobin electrophoresis, which is what you're seeing here, we lyse these red cells. And so I'm actually measuring an admixture of hemoglobin in solution. This does not represent necessarily what happens at the level of the cell. And that's really important. And I'm demonstrating that on this slide. So if I think about a normal, healthy person who does not have sickle cell disease, this is an approach where we're using a single red cell Western blot. And I was looking at someone who's perfectly healthy, all of their cells will be 100% beta A, and they would only have normal hemoglobin A. In contrast to someone who has sickle cell disease, where they cannot make hemoglobin A, and so 100% of their red cells make hemoglobin S. Now, I've used transfusions for decades to treat patients with sickle cell disease with great benefit. And when I do a hemoglobin electrophoresis, I might say that the patient only has, say, 30% hemoglobin S. Yet it's so important to recognize that it might be 30% hemoglobin S, but what I'm really saying is that 30% of their cells have 100% hemoglobin S, and that the remainder have hemoglobin A. Instead, what we're trying to achieve is something that looks like sickle cell trait, where we see pancellularity of hemoglobin S and A. And so the hope is that when we see distribution of hemoglobin A T87Q, that we'll see that the majority of their cells actually have both. And that's what we describe here. So these are the results of the single red cell Western blots for the first patients on this trial. Again, patients are transfused to prepare them for the study. And so at the beginning, they have 30% of their cells that are 100% S, 70% of their cells are 100% A. Over time, we stop transfusing them as they recover. And over time, what we're seeing increasingly is that for those patients who have at least 6 months of follow-up, 70% of the red cells in those individuals are a mixture of A and S. And those who have at least 18 months of therapy, that over 90% of their cells are a mixture of hemoglobin A and hemoglobin S. And so looking a lot more like sickle cell trait. But what's probably most important in terms of what does it matter to the patient? So this is actually looking at the first patients who were on this clinical trial, looking at the period prior to the 2 years prior to enrollment on this clinical trial in blue or purple, and the frequency of vasoocclusive pain episodes that are in diamonds on each one of those bars. And then contrasting that to the period following gene therapy in yellow or gold. and seeing that we have essentially a 99% reduction in the annualized rate of pain episodes following gene therapy in these individuals who've undergone this process, with one non-serious grade 2 vasoocclusive episode in a single patient about 3 months out. So again, very exciting gene addition approaches using beta globin. Now this is also gene addition, but taking a very different approach. And this is the work that's come out of Boston Children's Hospital, targeting a gene called BCL11A. BCL11A is responsible for our normal switching from fetal hemoglobin to adult hemoglobin. And so when BCL11A goes on, gamma globin goes off, fetal hemoglobin goes down, and we begin having adult hemoglobin. Has taken an RNA interference approach where they use a lentiviral vector that delivers BCL11A mRNA it actually uses a short hairpin interference approach on an mRNA background. And with the idea being that if you could deliver this short hairpin RNA, that you could actually cause binding and actually therefore silence BCL11A. And so the thought is that because this is more of what our body physiologically would do, that one would actually get something that looks closer to our normal erythropoiesis. This is one of the first patients that has now been described, and this patient initially had recurrent pain and had the classic sickle forms of red cells in their peripheral blood. But 6 months after gene therapy, had a total hemoglobin of 11 and no sickle forms in their peripheral blood. This potential cure is not without cost. A lot of the potential complications of gene therapy are related to the conditioning itself. And so busulfan is associated with mucositis, hair loss, risk of veno-occlusive disease, and lung fibrosis. Whenever we talk about potential transplantation, we always have to be concerned about graft failure. And the current requirement is that all patients have an aliquot of unmodified stem cells that are collected at the time that their cells are harvested for gene therapy, that are stored, but no patient has needed their stem cells to date. We also have to be concerned about clonal dominance or insertional oncogenesis. These certainly were absolutely issues that occurred in the early history of gene therapy using different kinds of viral vectors. Patients are evaluated every 3 months, and to date, there has been no evidence of clonal dominance or insertional oncogenesis. There has, however, been a single individual with sickle cell disease who developed myelodysplastic syndrome with monosomy 7. When evaluated very closely, the clone of their stem cells that contained monosomy 7 contained no copies of the BB305 lentiviral vector. And so the presumption is that their transformation was likely the result of busulfan, and certainly myelodysplastic syndrome is a known complication of busulfan. This individual went on to develop AML, underwent a transplant, but then had a recurrence and has died. Sterility and infertility is also a known complication of busulfan, and it is one that certainly is warrants long and serious conversations with families. All of them are offered some option for fertility cryopreservation prior to proceeding through gene therapy. I'm going to talk a little bit about genome editing, hot off the presses. Quite similar, but the difference being that as opposed to gene addition, genome editing is performed on their cells, and then their cells are reinfused. Genome editing in its current setting involves one of 2 platforms. One is zinc finger nuclease, a very stable platform, but certainly CRISPR has also been used, and in both cases, they have targeted BCL11A as a way to de-repress hemoglobin F, and then therefore to have a patient produce hemoglobin F as well as their native hemoglobin S. Of course, it goes without saying that it could not be more thrilled with CRISPR and Doctors Doudna and Charpentier receiving the Nobel Prize in Chemistry just weeks ago for their discovery of CRISPR. CRISPR Cas9 allows for precise genome editing. It requires double-stranded DNA breaks and the use of a guide RNA with the Cas9 nuclease that actually repairs these sequences. And the repair process can either be done by non-homologous end joining, which is really the method that is primarily used now in clinical trials. A less successful approach would be to target the use of homology-directed recombination as another approach, higher fidelity, but certainly more challenging. These are actually the early results that were just reported months ago in the first individual with sickle cell disease who was transplanted last year. She was a woman who had severe sickle cell symptoms, largely pain, with 74% hemoglobin S with intermittent transfusions. She was also on hydroxyurea and so had an elevated hemoglobin S. She was transfused prior to her stem cell transplant. And so at 1 month post-treatment with CTX1001, which is a CRISPR Vertex study, she had primarily hemoglobin A, but even already you see the emergence by 2 months of hemoglobin F. And then by 9 months, seeing that she has gotten rid of the cells from the blood bank, that green bar, which was the hemoglobin A from the transfusions, and now has a mixture of hemoglobin F from the CRISPR gene editing, and then hemoglobin S, her native gene. But again, pancellularity is going to be critical if these approaches are going to work. And what we can see in this slide is that compared to her native process, over time, she now has 99% of her cells that are now expressing hemoglobin F. But what's most important to this patient and to future patients is what impact is there on their most pressing symptoms. And so for this was a person who had repeated vasoocclusive pain episodes prior to enrolling in this clinical trial. And in fact, she continued to have pain episodes while she was being screened for this study. Yet after she had the infusion of her modified stem cells that now are capable of making more hemoglobin F, we see a complete correction. And in fact, she has had no vasoocclusive episodes to date, and she is now beyond the 1-year mark. Base editing, watch this box, is a new approach to gene editing. And so while more often than not, we talk about gene editing using nuclease editing as scissors. So whether it's CRISPR, zinc finger nuclease, or any of the other platforms that require double-stranded DNA breaks in order to make the correction. Base editing is a direct conversion of a single base pair. So instead of being scissors, imagine base editing being a single point mutation that you could basically erase and replace. And so this is an approach that actually has some terribly exciting preclinical data and is likely to reach the clinical trial state within the next 2 years. There's still some questions that remain. Will this single infusion be durable? Are there additional modifications that could further reduce risk? If we begin thinking about this in younger patients, will they do better? I mentioned to you a number of different vectors that are currently in clinical trials. Will the results with these different vectors be different, or will they align? And will genome editing achieve similar or superior results to gene addition? Finally, it's actually really forced us to actually ask a question: what constitutes cure? I would be remiss, however, in any conversation about sickle cell without talking about its global impact. We have 100,000 Americans with sickle cell disease, but there are 300,000 babies born every year worldwide with sickle cell disease. And by 2050, we estimate that it will increase by 30% globally. While I showed you at the early part of my presentation the successes that we're seeing in terms of survival, it's still important to point out that in certain lower resource countries in sub-Saharan Africa, that 50 to 90% of children will not see their 5th birthday. and that 75% of the world's burden of sickle cell disease is borne by countries in sub-Saharan Africa, the ones that are most heavily affected being Nigeria, the Democratic Republic of Congo, and also India. So while in the United States and in the UK, we have newborn screening, we've seen the benefits of newborn screening in terms of survival of children. We've also seen in countries like Jamaica and also in countries like Brazil, where the investments in early intervention with penicillin prophylaxis and treatment, they've also seen improvements in survival. It is unacceptable for us to continue to accept the difference for the continent of Africa. This is a cartogram, which is an intentional distortion of a world map to demonstrate the burden of this disease in Nigeria, the Democratic Republic of Congo, and India. It's been estimated that basic health interventions like newborn screening, penicillin prophylaxis, and vaccinations, that we could significantly reduce this XX mortality, and that by 2050, just with these public health measures, we could prolong the lives of over 5 million newborns with sickle cell anemia. And so to that end, it's really been my privilege as the president of the American Society of Hematology to oversee the investment in a newborn screening consortium in sub-Saharan Africa, where our goals are to establish a registry that will set standards for newborn screening in countries in sub-Saharan Africa and to advocate for early intervention. We've already started, and we are now up and running in 7 countries in sub-Saharan Africa. That was my 8 o'clock call this morning with our consortium, with our colleagues in Africa primarily, but also a handful of us in the United States. And we're so excited about the work that's being done and the promise that this holds for making a difference in Africa. And so in summary, we have unprecedented opportunities to advance research and to provide high quality medical care for patients with sickle cell disease. Hydroxyurea has been an effective agent to control many of the complications, but it's currently underutilized. So excited about the approval of new disease modifying therapies that expand options for patients. And certainly the early results with gene therapy and now gene editing are very promising. We know that there are knowledge gaps, and we hope that they will create opportunities for research and potential improvements in care. And I'd like to thank you for the invitation to join you today. Floor is open, I hope, for some questions.
Thank you very much, Dr. Thompson. That was an extraordinary lecture. And all of us who work at Tulane have to really be incredibly proud of you, your accomplishments, and your future directions. And we're delighted to have you with us, even though only virtually. Thanks.
I can't thank you enough. You know, I must point out, Bernie, when I arrived at Tulane, I thought I was going to be a general pediatrician, but I must tell you, my mentor, who has meant the world to me in terms of my career, I met as a medical student in New Orleans at Tulane. And were it not for that interaction, I dare say my career trajectory would have been quite different. And so I am deeply indebted to the opportunities that came to me as a Tulane medical student.
Fabulous. Are there questions?
There are questions typed in the Q&A box. Bernie, if you want, I'll read it.
That'd be great.
There's one comment and a question from Dr. Size, who's one of our new hematology faculty. Discontinuation of transfusion in pediatric patients as stroke prevention has shown to increase the risk in this pediatric population. Has this been studied in the adult population, and when would you discontinue transfusions in this adult population?
Great question. So really, we there's 2 things. One is that stroke prevention, it's a question of whether we're talking about primary or secondary stroke prevention, and whether we're talking about ischemic or hemorrhagic strokes. So most of these strokes in children are ischemic strokes, and we can clearly demonstrate that chronic transfusions, if you've had an ischemic stroke, will prevent repeat strokes by about 90%. Transcranial Dopplers in children are now being paired with transfusions for primary stroke prevention. So these children have elevated velocities in certain blood vessels, but they've never had a stroke, and that transfusions will prevent them. We're not sure why, but we've looked at that same approach in adults, and it does not seem to matter. So the transcranial Dopplers do not predict stroke risk in adults the way they do in children. I think what that means is that vasculopathy, hypertension, and other risk factors are in play in adults more so than they are in children. And so TCDs, unfortunately, have not been predictive. We don't have a measure for adults, but I do think that even in adults, given the neurocognitive deficits and the motor damage that can be caused by strokes, this is an area where we really need more work to be done. But today, transfusions for most of the pediatric patients will continue into adulthood, but there's not a clear role for adults otherwise to begin as adults to prevent strokes.
Thank you very much. Another question is, would you please speak to the ethical considerations regarding how patients are selected for potentially curable therapy?
I'm happy to, and I want to be clear that we are talking, that I want to clarify one key point, and that is for gene therapy for sickle cell, as well as the gene therapy programs that are currently ongoing around the globe, that by and large, we are talking about somatic gene therapy. What we are not talking about, and what we clearly are absolutely opposed to, is germline gene therapy. And I think for those of you who follow the news, certainly the modification in embryos that created 2 or 3 children in China was roundly criticized because I don't think that we are there. We do not understand enough about what the consequences are for modification of our genes to begin thinking about creating children as a result of gene correction. And so I think many of us right now see that as a clear line in the sand in terms of ethics. In terms of patient selection, these are still clinical trials. And so by and large, we're looking at people who meet the criteria for entry into the clinical trials and who are interested. But these are pretty rigorous processes. And so as long as someone is eligible for the clinical trials, there is no selection process beyond their ability to actually comply with the procedures. We have extended down into the pediatric age range, and I think some of the ethical issues come up when we talk about children, especially when we're talking about infertility. We're reasonably confident that we can actually cryopreserve, we can use fertility preservation methods for adults into children down to puberty. But once we get into the earlier years of childhood, it's experimental. I benefit from being in an institution that's very active in oncology. And so we actually have clinical trials that are currently ongoing for children who have cancers and looking at cryopreservation for them. And so patients with sickle cell disease and thalassemia are enrolled in those trials. And so every family is given an opportunity, irrespective of their ability to pay, to ensure if they choose to undergo these procedures, that they will have the ability to retain fertility if at all possible.
Thank you. The next question is regarding renal complications, and are the new therapies promising improvement on those?
You know, I really hope so. I couldn't agree with you more. It is so horrific for me to have done everything that I thought I could possibly do to deliver what I think is a healthy young adult to my young adult in transition from pediatric care to adult care. Yet many of them may go into adult care with a little bit of microalbuminuria. And then within 3 years, they're on dialysis. I mean, it is absolutely horrific. I think that we're learning more about risk factors for the progression of kidney disease and sickle cell disease. It has some features of FSGS, but their progression from the early stages of CKD through end-stage renal disease is far faster than other African Americans. And so this is definitely a process that we desperately need to understand better, that kidney failure is a common cause of death in young adults with sickle cell disease. We have looked at the benefits of the current therapies for kidney disease, and we can say that hydroxyurea and an ACE inhibitor combined slows down the progression from proteinuria to actual stage 2 or 3 CKD, but not preventing it. And so I think that we still have a ways to go. This is the times when I believe, even when I showed that early picture of all those different cell organ systems that are affected by sickle cell, my hope is that whether you're going into orthopedic surgery, psychiatry, radiology, nephrology, you name it, I'm going to make an argument for you to care about sickle cell disease because I need your help. And so whether it's women with sickle cell who are likely to have complicated pregnancies, or individuals who have moya or vasculopathy who can now undergo procedures to improve vascular blood flow by neurosurgeons. There's a role for almost every subspecialist to improve the lives of people with sickle cell disease. So even if I haven't convinced you to be a hematologist, I hope I've at least tweaked your interest in looking at your opportunity to improve outcomes for people with sickle cell disease.
Thank you very much. We have a few minutes left. I'd like to turn it back to Dr. Jaffe, Ashley Vellucci, and Kyla Street if they have any closing comments. But before I do that, I would like to personally thank you very much for this inspiring presentation. We really enjoyed having you and look forward to seeing you again in the future. Dr. Jaffe, Kyla, Ashley, any closing comments?
So I'll close by saying how much inspiration you provided for us today. I hope there are an awful lot of medical students who are listening, and I certainly hope they all recognize what the options for the future of their careers are and how it's possible to really change the world by going into medicine at all fields, and that Tulane trains them to be able to do that in a way that is going to make us as proud as we have the potential to be proud of you. So thank you very much for being here and for being our AOA visiting professor. We do look forward to having you here in person. New Orleans is a great place, as you probably recall, and we'd love to have you visit, and we'll arrange that as quickly as it's safe to do. So
Sounds wonderful. I look forward to it.
Thanks for coming, and thanks for being so stupendous. And this is a remarkable lecture. Thank you for everything.
Thank you. Ashley, Kayla, any last words from either one of you?
Yeah, we just wanted to say, thank you so much for speaking today at our grand rounds. We really appreciate it, and in the future before we graduate.
Yeah, I would love to meet you guys in person before you graduate. So let's try to, the pandemic allowing, I'd love to make that happen.
Yeah, we will try everything we can.
Sounds good. Okay, well, you all take care.